Uveal melanocytic tumors. Melanocytic tumors of the iris. Nevus. Benign melanocytic cellular proliferation resulting in a flat mass with variable pigmentation. Pathology. Localized mass, diffuse iris stromal flat lesion, variable pigmentation, ectropion iridis, angle involvement, and sector cataract. Diffuse or segmental iris nevus is present in oculodermal melanocytosis. Microscopic picture. Bland-looking, proliferating spindle cells with variable pigmentation. Occasionally deeply pigmented round cells, melanocytoma. Malignant transformation is rare. Iris melanoma. Etiology. This is the most common primary iris neoplasm, 5% of all uveal melanomas. Pathology. Circumscribed type. Nodular iris stromal mass, ectropion iridis, angle involvement, cataract, spontaneous hyphema, chronic uveitis, documented growth, the most reliable sign. Diffuse type. Heterochromia iridis, sectorial iris pigmentation, satellite lesions, and early angle involvement. Complications. Secondary glaucoma, direct angle invasion, melanomellitic glaucoma, peripheral anterior synechia, neovascular glaucoma, and secondary angle closure glaucoma. Low-grade spindle B cells, 60%. Mixed cell type, 30%. Epithelioid and spindle B cells. Epithelioid type. Prognosis of iris melanoma. Metastasis as posterior uveal melanoma, mostly to the liver, in less than 10% of cases. 5-year mortality rate, 5 to 15%. Differential diagnosis of iris masses. Nevus, iridocorneal endothelial syndrome, iris leiomyoma, iris metastasis, rhabdomyosarcoma, ciliary body melanoma, inflammatory masses, juvenile xanthogranuloma, granulomatous inflammation, Busaka, Copen nodules, TB, sarcoid granuloma, iris foreign body, iris cysts, implantation cysts or primary iris cysts. Iris metastasis, loosely cohesive yellow-pink mass, pseudohypopion in a quiet eye, endophthalmitis-like presentation, masquerade syndrome. Iris granuloma, chronic granulomatous iris inflammation, specific or non-specific. Iris cysts, stromal cysts, types, primary or post-traumatic, location, mid-stromal, pupillary or peripheral. Iris pigment epithelial cyst, origin, pigment epithelium, projects from behind pupillary border, it has clear contents. Iridocorneal endothelial syndrome. Ciliary body nevi. Benign melanocytic tumors constituting 6% of all uveal nevi. Rare presentation due to hidden nature of the lesion. Ciliary body melanoma. It represents 9% of all uveal tumors. It reaches large size, invades the anterior chamber, manifesting as iris lesion and extending along aqueous outflow pathways. Types. Diffuse ring type ciliary body melanoma. Induces ring configuration around circumference of angle and ciliary body, prone to anterior extrascleral extension. Effects on surrounding structures. Sectoral cataract and lens subluxation. Prognosis, worse prognosis than choroidal melanoma. Choroidal nevi. Incidence, 35% of adult population. Choroidal nevi occur in 1 to 6% of overall population. Site, 90% behind equator. Pathology. Flat discoid lesions. Size, 3 mm, 1 to 11 mm. Minimally elevated, less than 2 mm. Surface, drusen, choroidal neovascular membrane, and serous retinal detachment. Nevi are relatively avascular, early hypofluorescent. Microscopic picture. Cells occupy full choroid except choriocapillaris, benign melanocytes, plump polyhedral cells in melanocytoma, spindle A cells, fusiform and dendritic cells, balloon cells. There is normal vascular pattern. Prognosis. The following factors predispose choroidal nevus for growth: posterior pole location, thickness more than 2 mm, orange pigment, presence of subretinal fluid, and presence of symptoms. Choroidal melanoma, most common primary intraocular malignancy in fair complexion adults. Origin: dendritic melanocytes, neural crest, neuroectodermal in origin. Age: median age at diagnosis is 53 years. Race: white Europeans 6 per million. Whites to blacks 8.5 to 1. It is unilateral. Predisposing lesions: congenital ocular or oculodermal melanocytosis, nevus of Ota. The incidence of choroidal melanoma in oculodermal melanocytosis is 1 in 400. Uveal nevi. Estimated rate of malignant transformation is 1 in 5,000 per year, or it may occur de novo. Choroidal melanoma could be pigmented or amelanotic. Degree of pigmentation reflects different cell lines. Pathology: surface orange pigment, secondary retinal detachment, and occasional vitreous hemorrhage. Choroidal melanoma could be dome-shaped or mushroom-shaped due to rupture through Bruch's membrane. There is also the diffuse infiltrating type with flat growth pattern. Spread: intraocular spread, Bruch's membrane invasion, occurs in 63% of cases. Tumor shape changes from dome-shaped into a mushroom shape. Bruch's membrane obstructs tumor venous circulation, leading to dilated tortuous venous channels. Retinal invasion and vitreous spread may occur. Optic nerve invasion. Optic nerve resists invasion. Occurs in 5% of peripapillary melanoma. Extrascleral extension and orbital spread, posterior ciliary arteries and nerves inducing orbital mass with proptosis. Anterior emissary vessels causing episcleral mass. Vortex veins 13%. Sampling of vortex veins should be done routinely on histological sections. Tumor orbital recurrence rate following orbital spread is 18% compared to 0.7% in absent detectable extraocular extension. Scleral invasion, postoperative, post-cataract extraction, post-lamellar resection. Systemic spread, hematogenous, intratumoral vascular invasion, vortex vein invasion. Veins should be sampled separately at enucleation. Tumor spreads hematogenously to the liver. Clinically significant factors for metastasis: documented growth, tumor touching optic disc margins, tumor thickness more than 3 mm, and visual symptoms. Classification and characteristics of choroidal melanoma according to largest tumor diameter. Small choroidal melanoma, largest tumor diameter 10 mm, thickness 2 to 3 mm, shape dome-shaped. There could be extrascleral extension, but there is no diffuse infiltrating type. Medium-sized choroidal melanoma, largest tumor diameter 11 to 15 mm, thickness 3.1 to 5 mm, shape mushroom-shaped, breakthrough Bruch's membrane. There could be extrascleral extension, but there is no diffuse infiltrating type. Large choroidal melanoma, largest tumor diameter more than 15 mm, thickness more than 5 mm, shape it may fill the globe. Extrascleral extension is more common. There is lateral spread with minimal choroidal thickening and orbital invasion. Histopathological classification, calendar classification modified by MacLean at 1978. Association between mortality and cytology or cell type of melanoma. Spindle cells, bipolar cells with spindle-shaped cytoplasm, arranged in parallel fascicles and grow as syncytium. Cellular margins indistinct by light microscopy. Spindle A, 5% of cases. Slender cigar-shaped nucleus with finely dispersed chromatin and absent nucleolus. Nuclei often have chromatin stripe or streak caused by fold in nuclear membrane. Mostly benign and represent spindle cell nevi. Spindle B, 39% of cases. Larger oval nucleus with coarser chromatin and a more prominent nucleolus. Fascicular type, 6% of spindle B. Subtype of spindle cells refers to a tissue pattern where tumor cells are arranged in parallel rows, bundles, or palisades. Epithelioid cells. Epithelioid melanoma cells, 3% of cases, mostly malignant. Polyhedral cells with abundant glassy cytoplasm. Large and pleomorphic, bizarre giant cells occasionally seen. Poorly cohesive, with distinct cytoplasmic borders. Large round to oval nucleus, with peripheral margination of course. Chromatin clumped along interior of nuclear membrane. Prominent eosinophilic or purple nucleolus, and mitotic figures. Subcategories of tumors based on cytology, cellular constituents. Spindle cell nevus, spindle cell melanoma. Spindle cell nevus, composed entirely of benign spindle A cells. Spindle cell melanoma, composed of malignant spindle A and B, or spindle B cells. 15-year survival rate, 75%. Mixture of spindle and epithelioid cells, 5-year survival, 40%. Epithelioid cell melanoma. It is rare and has the poorest prognosis. Composed predominantly of epithelioid cells, 5-year survival, less than 30%. Necrotic cell type, 7% of cases. Massive tumor necrosis due to tumor outgrowing blood supply, intraocular inflammation, autoimmune process with plasma cells present. Types of cells are unidentifiable. Prognosis as mixed cell melanoma. Prognostic features. Cell types. Cell type modified calendar classification. Patients with spindle cells tumors have better prognosis than patients whose tumors contain epithelioid cells. Survival rate related to melanoma cell types. Spindle cell melanoma, 5-year survival, 90%, 10-year survival, 79%, 15-year survival, 72%. Mixed cell, epithelioid cell, and necrotic melanoma, 5-year survival, 58%, 10-year survival, 44%, 15-year survival, 37%. Tumor size. Tumor size is as important prognostically as cell type. Tumors can be difficult to accurately measure. Largest tumor diameter is the best prognostic indicator. Survival rate related to melanoma largest tumor diameter. Small, less than 11 millimeters. 5-year survival 86%. 10-year survival 76%. 15-year survival 70%. Medium, 11 to 15 millimeters. 5-year survival 66%. 10-year survival 51%. 15-year survival 43%. Large, more than 15 millimeters. 5-year survival 56%. 10-year survival 41%. 15-year survival 35%. Mitotic activity. More mitosis means worse prognosis. Extraocular extension. Necrosis. More necrotic tumors have worse prognosis. Anterior location. Ciliary body tumors worse than choroidal melanoma. Size and variability in nucleolar size. Standard deviation in nucleolar area. Vascular patterns. Closed vascular loops. Large vascular space occluded by melanoma cells. Vascular networks. 3 back-to-back closed vascular loops. Lymphocytic infiltration. Predominantly suppressor to cytotoxic T lymphocytes, associated with worse prognosis. More malignant melanomas may be more antigenic. Diffuse melanoma. Metastasis is 24% at 5 years. Diagnosis of posterior uveal malignant melanoma. Indirect ophthalmoscopy, 99.7% accuracy. Fluorescein angiography, early venous hyperfluorescence, late mottled staining, visible prominent tumor vessels, double circulation. Ultrasonography, opaque media, initial evaluation of thickness, follow-up of treatment response. A scan, low to medium reflectivity. B scan, acoustic hollowness, choroidal excavation, positive angle kappa. Transillumination, a forgotten art. Office exam, opaque media, positive transillumination defects, valuable in differential diagnosis. CT, MRI, add little to diagnosis. Radioactive phosphorus 52 uptake, highly accurate, requires conjunctival incision. There is infrequent use. Fine needle aspirations biopsy, highly reliable technique, done in cases with uncertain diagnosis. Difficult technique, needs an experienced cytopathologist. Investigations, ocular ultrasound, liver function tests, abdominal ultrasound, and chest X-ray. Differential diagnosis of posterior uveal melanoma. Melanocytoma, a maximally pigmented magnocellular nevus. Etiology, it's more common in blacks, classically an optic nerve tumor. Pathology, may increase in size. Malignant transformation is extremely rare. Bleaching sections required to disclose cellular details during diagnosis. Balloon cells, plump polyhedral nevus cells. Congenital hypertrophy of retinal pigment epithelium, halo nevus. Flat black circular or oval lesion with depigmented lacunae and surrounding halo. Retinal pigment epithelial cells are hypertrophic and show macromelanosomes. Induces a localized scotoma. It has no malignant potential. Congenital hypertrophy of retinal pigment epithelium-like lesions are found in Gardner syndrome, familial adenomatous polyposis, colon carcinoma, extracolonic manifestations. Congenital hypertrophy of retinal pigment epithelium-like lesions are bilateral, multiple, oblong pigmentation that do not resemble sporadic solitary congenital hypertrophy of retinal pigment epithelium or typical bare tract. Hemorrhagic vascular lesions, extramacular hemorrhagic chorioretinopathy, peripheral disciform degeneration, age-related extramacular degeneration with subretinal hemorrhage and exudates. Inoscyanine green angiography reveals an occult extrafoveal choroidal neovascular membrane. Hemorrhagic detachment of retinal pigment epithelium or retina, subretinal well-defined elevated mass, blocked fluorescence, vitreous hemorrhage. Inflammatory lesions, chorioretinal granuloma, tuberculosis, sarcoidosis, or syphilis. Cystic lesions, degenerative retinoschisis, iridociliary cysts. Choroidal detachment follows intraoperative surgery due to intraoperative or postoperative ocular hypotony. Fluid accumulation in the suprachoroidal space. Choroid and ciliary body are stretched out by an eosinophilic coagulum. Uveal effusion syndrome, bilateral exudative retinal and choroidal detachment. It affects middle-aged males and is idiopathic. Association, thickened sclera with proteoglycans deposition, abnormal vortex veins with impeded drainage, nanophthalmic eyes, and primary pulmonary hypertension. Pathology, dilated episcleral vessels, exudative retinal detachment, annular choroidal and ciliary body detachment, minimal vitreous cells, and leopard skin retinal pigment epithelial changes. Prognosis, spontaneous reattachment may occur. Leukemia, choroidal infiltration by leukemic cells, retinal involvement by leukemic cells. Subretinal hemorrhages may mimic choroidal melanoma.